Okay, thank you, Chris. So the basics are that we know about 20 to 30 percent of patients who come for cardiac surgery happen to be in AF. And as the famous song in Casablanca said, you must remember this, the fundamental things apply. And that is, the question is there a symptomatic indication for doing something for the AF? And is there a prognostic indication? Now, as ever, the symptomatic indication is always straightforward. If they have symptoms that you cannot control with medical treatment, then you offer them surgery. So if the patient has palpitations that are not being controlled by medical treatment, then you should do a maze, because at the same time as the operation, we have lots of evidence that a maze is much more likely to have them in sinus rhythm and get rid of their palpitations. The prognostic indication is a little bit more complicated than that. And we just go over some of the background for this. If it's present in about 40% of mitrals and about between 5 and 10% of other surgery patients, traditionally we just ignored it. For years and years and years, we pretended that there was no AF. And the only good thing about having a patient with an AF, with AF in surgery is that you could save on pacing wires and not have to use an atrial pacing wire at the end of the case. So things were a little bit quicker rather than slower. Now, all this has been changing over the last few years, but the change has been inconsistent. We all know that the Cox cut-and-sew maze is amazingly effective from the series that we have seen. I don't think the cut-and-sew maze has ever been subject to a randomized clinical trial. But the take-up by the surgical community has been really low. I remember it was in Manchester in 1990, I think, that I first heard about the Cox cut-and-sew maze. I didn't understand what it was about, but I did notice that over the subsequent 20 years, the number of patients that have had it are in probably the order of a few thousand worldwide. So it hasn't really taken off in 20, 30 years. And the reason for this are obvious. It's demanding, it's time-consuming. There are lots of incisions and lots of bleeding sites, so it's used very, very selectively. And if we look at the UK, the number of surgeons who practice cut-and-sew Cox maze is tiny. The number of patients that they offer the procedure to is also tiny. And I believe that there is a higher mortality and complications with it. This is not a proper scientific series, but over 2 years, 50 maze procedures were done in one institution, 40 were device-based, and 10 were cut-and-sew. There were no deaths in the device-based ones. There were 3 deaths amongst the 10 cut-and-sew. So I actually think cut-and-sew maze is on its way out. And I apologize for saying that if it upsets any members of the audience who still practice it, but I think it's dying. So this has changed everything. It made the procedure easier, quicker, it made it accessible to most surgeons, and it made it much more attractive to surgeons. And there has also been a little element of industry drive to try to push this procedure through. And there have been many devices and many lesion sets and lots of different surgical approaches to the problem. So we have a lot of variability. First is whether the AF is actually considered for treatment at all in the patient who's coming in for a heart operation for something else. And if it is considered an option, then what lesion set is used, what device is used, and how the patient is managed afterwards is still highly variable. So why not do a maze when you have a patient who comes in for a heart operation, regardless of what that operation is? Well, assuming that sinus rhythm is actually desirable, we want to achieve sinus rhythm in patients because AF is bad for you, then I think these are the reasons why it doesn't get done. First, the long tradition of ignoring it. And as you know, tectonic plates move faster sometimes than some surgeons' attitudes. So it's not surprising that once you're stuck with ignoring AF, you will continue to ignore AF. There is some evidence of lack of familiarity with the maze procedure. If it's not done in your institution, you haven't seen it done, or you haven't actually trained in an institution which deals with it, then the lack of familiarity might put you off. And there is also a little lack of belief that you will actually achieve sinus rhythm in many subcategories, including those with very long-standing AF or big atria, poor left ventricle, or especially those in whom the cardiac functional lesion has not been fixed completely. It's interesting listening to Mark's talk that the success rate of restoring sinus rhythm at 1, 2, and 5 years in randomized controlled trials is only about 60%, whereas when you see individual series, that's where we see the 80, 85, 90, 95% success rate. And it just makes me wonder, why is it that when you enter a randomized controlled trial, the success rate drops? I suspect series are quite highly selective. So the other reason not to do a maze is that you may have started doing it and you weren't particularly impressed with the results that you were getting at the beginning. So incomplete lesions and sort of the minimum mini maze or minimal ablation that you could get away with could be the reason. And there is also incomplete treatment, because we're surgeons and our tendency is to operate on the patient, see them once in clinic, and if they're still breathing, send them away, never to be seen again. And of course, that's not good enough, because the treatment completion of the maze procedure is done at 6 weeks or 8 weeks when you cardiovert them back into sinus rhythm, and then potentially again at 6 months if they've gone back into AF, and perhaps some people say at a year. So you should persist. And persistence hasn't really been one of our strongest features. There is obviously a reluctance to increase the surgical complexity. Theatre time is precious, our time is precious, and we only tend to do things that we know are going to achieve a very good result. There is a reluctance to do it in redo procedures, because you have to go into tiger country where there are adhesions that you normally wouldn't touch. If you wanted to do a full maze, that you're doing a redo aortic valve, you wouldn't even go to the back of the left atrium. There is a fear of flutter, which some people have described as actually worse than the AF. So if you have an incomplete lesion set which brings the patient back with left atrial flutter, that can be very, very difficult to treat. And then there is, of course, the cost. And these disposable devices cost thousands of pounds. And if you're a rich hospital using the specific device for every specific lesion, a right-handed clamp and a left-handed clamp and an upside-down clamp with a light at the end of it, and a bit of cryo and a bit of this, that, and the other, it can actually mount. So we can solve some of these problems by having better education. So I think the message has come through already today that the lesion sets really have to be complete, because the more complete the lesion set, the better the outcome. And the lesions themselves must be complete. And you heard Manuel today talk about the importance of achieving a transmural lesion, which cannot be achieved with just a quick buzz. And the surgeons themselves must be quite comfortable with the maze procedure. And in my opinion, this comes most readily from attending courses and transfer of information between surgeons, and perhaps surgeons looking at how other surgeons do it and picking up the technical tips. It's important to complete the treatment by cardioversion. This really must be emphasized, and it tends to be forgotten in the outpatient clinic. And hopefully the costs will come down. Now, I think sinus rhythm will be restored in about 70 to 90% if all of these procedures, all these caveats are paid attention to. And then hopefully faith will be restored in the procedure as a good one. But, and this is quite a big but, the patient really does not care about the ECG. We might care about the ECG, and we might self-congratulate for having a patient in clinic with sinus rhythm, but the patient really, they don't really care about that. What they care about that is, are they going to live longer? Are they going to feel better? And are they going to avoid complications? So really, it's the outcomes that matter to the patients are those of survival and quality of life. They're the things that matter most. And then, if you do actually achieve some improvement in survival and quality of life, is the treatment cost effective? Does it justify the extra cost? So that's why we did the AMAZE trial, which is a big multi-center UK trial, double-blind, randomized between maze and no maze for patients having cardiac surgery. These are the recruited patients. Every type of AF was brought in, and every type of heart operation. We excluded patients who were redos for reasons I alluded to earlier. We excluded emergencies because obviously we couldn't randomize them. And we excluded off-pump because you can't really do a full maze off-pump. But the overwhelming majority of patients were eligible. Patients who come to a hospital cardiac surgery who happen to be in AF were eligible. So the primary outcome is going to be return to sinus rhythm, but the other primary outcome, which is the most important in my opinion, is the clinical effectiveness, which means quality-adjusted survival and quality of life. And we're looking at this at 6 weeks, 6 months, 12 and 24 months after surgery. There are lots of secondary outcomes, which I think you can probably guess, so I won't list them all. And we've learned a few things from the AMAZE trial, but unfortunately nothing that's going to be of any interest to you today, because the results haven't really been analyzed. One thing is that I've learned very strongly is that surgeons usually overestimate their recruitment prowess. So we were supposed to finish the recruitment in 2 years, and it took us over 5 years to nearly finish it. And and then there is this problem of surgeons who say, yes, of course I'll enter the trial because there is equipoise. But then when a patient comes in, the surgeon somehow knows whether AMAZE is a good idea for that patient, and therefore they make the decision and don't enter them into the trial. I think anybody who's tried to run a surgical RCT has probably encountered that particular problem. So we've managed to recruit 352 patients. That recruitment stopped in May 2 years ago, which means in May the last patient will have come to 2-year follow-up, and the analysis has already started. We will be adding the last patients to the analysis in May, and the results will hopefully be published by the end of the year. But in the meantime, I can tell you that there are no safety issues. Concomitant MAZE did not appear to make the procedure associated with higher mortality or morbidity. I can tell you also that mortality in both the trial and the control group was relatively high, and that's really just an indication that the patients who come to surgery with AF are actually an old and sick bunch. These are impressions, and they certainly have not come from the AMAZE trial, but in the same way as other randomized controlled trials, the rate of return to sinus rhythm with the MAZE is a little bit surprising when you actually do a randomized controlled trial rather than a series. And also the rate of return to sinus rhythm in patients who have not had the MAZE, who are in the control arm, but who got the same treatment as those who had the MAZE, is also probably going to be surprising. And there may be an operator dependent difference in the outcomes, and that might be related to experience, and might be related to the lesion set, or it might be related to a combination of both. Now, so to come back to the vexed question of the lesion set, cruel people who don't like surgeons very much have said rather uncharitably that there's probably as many lesion sets as there are cardiac surgeons doing them. So I can assure you absolutely that this is not the case, because we have recruited 178 trial patients who had the MAZE, and there were 30 surgeons involved, and there were actually 76 lesion sets, which actually means that really was unfair. There are twice as many lesion sets as there are surgeons doing them. So the next question is, do we actually restore sinus rhythm that matters to the patient in terms of function? Is there an atrial kick? Is there something that's going to reduce the risk of stroke? And is there something that's going to avoid anticoagulation? Well, this is the next study, which is a subsidiary of the MAZE. And what we're doing is we're looking at atrial function by MRI and echo. And here we're not comparing those who've had the MAZE and those who haven't, but we're comparing those who got their sinus rhythm from the MAZE with identical patients who had the identical operation, but whose sinus rhythm comes from nature. That means they've never had AF. And the idea is to, by having patients who are so similar and comparing their atrial function one with the other, we can tell just how much restoration of normal atrial function, if any, you actually get with the MAZE. This study is actually finished, and we're actually analyzing it now. So we're going to find out how many get a functional atrium, how much function, and who is it that gets it, because we think this will be a huge guide to knowing what to do with the patients in the long term if they are in sinus rhythm. I'm sure many of you know, loads of cardiologists say no matter how much you got them in sinus rhythm and how stable that is, if they've been in AF, they should stay on anticoagulants forever, because they don't trust our atrial function after MAZE. So this is, because of the HESTER study, I actually started thinking, well, perhaps I should be looking at these things myself and seeing whether are we getting atrial function after MAZE. So this is a patient who had chronic AF for over 6 years, I think, and this is his MRI post-op. He's in sinus rhythm now, and there are lots of things to be happy about and other things not to be happy about. But the one thing that's really nice in there is if you just look at that atrial kick. Do you see that? I mean, that's phenomenal. That's a brilliant atrial contraction. I would say that that actually classes as normal atrial function. So, yippee, let's stop the warfarin. However, if you look over here, where an exclusion of the left atrial appendage took place by suture from inside, which at surgery looked complete and was done in 3 layers of Prolene, it looks like it's recanalized through a tiny little hole. So we still have a left atrial appendage. Oh dear, that's a tragedy. We better not stop the warfarin. But then, if you actually look at the left atrial appendage itself, it's contracting very, very well, and it is pushing all of its blood through this very powerful jet back into the left atrium. So there is no status here. So, yippee, let's stop the warfarin. Does anybody know the answer? I'm afraid I don't. So at the moment, adjunct MACE is not offered to more patients because of culture, because of lack of faith in effectiveness, because of possibly the bad effect of early personal experience, and because of a desire to simplify surgery and cost. And there is still, unfortunately, not much in the way of definitive hard proof of an impact on prognosis. So for those patients whose AF is asymptomatic, it is still a little bit difficult to tell them that there is absolutely first-class evidence they will live longer if you fix their MACE, if you fix their AF. MACE is not a lifesaver yet. So are we dealing with AF appropriately? Well, probably not, because there's too much variation in all the factors that I've discussed with you already, and it's a little bit like religion, you know. If you have 150 religions that say completely different things, they can't all be right at the same time. So some of us, surgeons, must be wrong in the way we're handling AF. And we're not really entirely to blame, because we have suffered a lot from lack of evidence in this area. However, the knowledge base is evolving, and these trials, amongst others, will hopefully answer these questions. So watch this space. Thank you.